Welcome back to the deep dive. So when you hear the word Botox, you probably think, smoothing out wrinkles on a forehead.
Right, cosmetic stuff.
Exactly. But today, we are going completely the other way. We're looking at its use deep inside the body to fix really serious problems in the digestive system.
And for this, our source material is pretty specialized. We're basing this deep dive on insights from advanced practitioner training, specifically from a video on Dr. Gadamukala S. Raju's professional YouTube channel.
That's a key point. This isn't about looks, it's about function. So our mission here is to walk you through how Botox actually works in GI endoscopy, what it treats, and maybe the most surprising part, how incredibly delicate you have to be to even prepare it.
It all comes down to a really simple principle. You inject Botox into a muscle, and it tells that muscle to relax, to stop spasming.
So in the GI tract, if a muscle is too tight and causing pain or blockage,
You introduce Botox for a very, very targeted local relaxation. It's relaxation by design.
okay, let's unpack that. Let's start with maybe the most critical use, a condition called achalasia.
We're talking about the lower esophageal sphincter, the LES. That's the muscle at the bottom of the esophagus that's supposed to open up and let food into your stomach.
And in achalasia, it just doesn't. It's stuck shut. It's in a state of chronic spasm.
Which means food and liquid, they just back up.
Yeah.
Swallowing becomes this huge struggle.
Yeah, patients often complain about regurgitating food, sometimes hours after they've eaten. Stale food, it's awful.
Now, normally when you treat achalasia, you hear about these more permanent, aggressive solutions.
Sure, things like a balloon dilation to stretch it open, or a myotomy, the Heller or Puyem procedures, where they surgically cut the muscle.
So where does Botox fit in? It seems much less invasive.
It is, and that's the point. It's really a lifeline for patients who are too frail for those bigger procedures.
So it's for high-risk patients.
Exactly. Older patients, people with lots of other health problems who just can't tolerate a major surgery or even a dilation, Botox is their option.
So you're making a trade-off. They can't handle the permanent fix, so they get a temporary one instead. And that is the crucial detail. The results, they don't last very long.
How long are we talking?
Maybe 6 months, a year, tops. You're basically offering temporary relief to give them back their quality of life, to let them eat and drink again without the risk of a major surgery. You're buying them time.
That's fascinating. A temporary drug for a chronic condition. So this idea of targeted relaxation, it's not just for the esophagus, right?
No, not at all. The pyloric sphincter is another big one.
That's the exit from the stomach.
Right. And when that spasms, food can't get out of the stomach properly. So you get this constant nausea, pain after eating, and, vomiting of old, undigested food. Injecting the pylorus can bring immediate relief.
So we're seeing a pattern, but there's one condition where Botox used to be an option but isn't so much anymore. Sphincter of Oddi dysfunction, SOD.
Yeah, and this is interesting because it shows how medicine evolves. SOD causes this terrible abdominal pain, can even trigger pancreatitis.
Yeah.
And Botox worked. It relieved the spasm, but better, more permanent treatments came along. We got better at surgically managing that sphincter. So Botox, being temporary, sort of fell out of favor for that specific use. It's not that it didn't work, it's just that something better replaced it.
That makes perfect sense. Okay, let's go to a different part of the GI tract, much lower down, for an application that sounds really surprising.
We're talking about an internal anal sphincter spasm.
Yeah.
This is usually what's behind an anal fissure.
And the patient experience here is pretty brutal, I imagine.
Oh, it's terrible. We're talking about severe, searing pain with every bowel movement, often with some bright red blood right at the start of the pain.
So how does Botox provide this elegant solution here?
The mechanism is actually beautiful in its simplicity. The anal fissure is a small tear, and the muscle spasm keeps pulling that tear open. It never gets a chance to heal.
It's constantly under tension.
Exactly. So you inject Botox, relax that internal sphincter, and you give the tissue the quiet time it needs to finally repair itself. You're enabling the body's natural healing process.
This is great. But before any of this can happen, you have to actually prepare the drug. And this is the part that, frankly, blew my mind. The level of gentleness required.
It is shockingly fragile. I mean, it's usually the nurse who does the reconstitution, but everyone in that room has to understand this. You take a 23-gauge needle, a 5 cc syringe, and you draw up 5 milliliters of sterile saline.
Okay, that sounds pretty standard, but the next step is the key.
It's everything. You have to inject that saline into the Botox vial. Slowly. Really, really slowly and gently.
Why? What happens if you just push it in quickly?
You destroy the drug. The sheer mechanical force of the liquid hitting the powder will denature the neurotoxin. It becomes useless.
Wait, hold on. This stuff can paralyze muscle tissue, but a little bit of water pressure from a syringe can just break it.
It's that fragile, and it gets even stricter. The mixing rule. You absolutely cannot shake the vial.
Do not shake.
You just gently rotate it. If you shake it, you've destroyed the drug. All you will be injecting into the patient is saline. No therapeutic effect whatsoever.
That is just staggering, the delicacy needed for something so powerful.
It's high-precision chemistry before you even get to high-precision medicine.
Okay, so once it's been so gently prepared, let's go back to the LES for achalasia. The endoscopist is ready to inject. What happens inside the patient?
Well, first, you often have to clean up. In an achalasia patient, the esophagus is usually full of froth and liquid that's backed up. So the first job is to suction all of that out so you can actually see the sphincter.
Right, clear the field. And then the injection itself.
It's a very standard quadrant approach. The endoscopist uses the needle through the scope and injects 25 units of Botox into each of the 4 quadrants.
4 quadrants, so like a clock face.
Exactly. 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. 100 units total delivered right into that spastic muscle.
And the relief is pretty immediate, right? But are there any side effects from this sudden relaxation?
The sphincter relaxes very, very quickly. But patients might complain about 2 things. First, some mild chest pain as that muscle finally lets go of all that tension.
And second?
Heartburn. Because that sphincter is now so relaxed, it's easier for stomach acid to reflux back up.
A bit of heartburn seems like a small price to pay for being able to eat again.
Absolute.
But now we have to get to the safety part, which is non-negotiable and, frankly, a little scary.
It is. This goes way beyond just standard masks and gloves. Everyone in the room, the whole team and the patient, needs full eye protection. Full PPE for the team.
And let's be very clear about the why. What happens if a tiny drop of the solution splashes into someone's eye?
It's not good.
It causes paralysis of that eye muscle. You get a squint.
A literal squint from an accidental splash.
A functional physical injury. It's why the source material is so emphatic about covering the patient's head and eyes with a towel. It's that extra layer of defense.
It's such a stark reminder. You're using a poison as a therapy, and you have to respect its power every single second.
The vigilance in that room has to be immense. The toxicity drives the vigilance. So, if we pull this all together, we've seen Botox used for targeted relaxation all over the GI tract. For the LES and frail achalasia patients, for the pylorus, for healing and anal fissure. We've learned that preparing it requires this incredible counterintuitive gentleness, and that administering it demands extreme safety precautions to avoid, paralyzing someone's eye.
The contrast is just so fascinating, isn't it? You have this famous neurotoxin, mostly known for cosmetics, being repurposed as this critical temporary lifeline.
It's the highest stakes use of a temporary fix.
It really is. And the delicacy required to handle the molecule, it stands in such sharp relief to the dramatic, immediate physical result you see when that locked up muscle just lets go.
So let's leave you with a final thought, and it comes back to achalasia. If Botox is the temporary fix for high-risk patients, and it only lasts, say, 6 to 12 months, at what point does the risk of doing repeated temporary procedures start to outweigh the risk of that one big permanent surgery they were trying to avoid in the first place?
What are the factors that go into that calculation? When does the balance tip?
It makes you think about that risk-reward timeline for these very vulnerable patients. A really complex ethical and medical question.
Something to consider for sure.
Thank you for joining us for the deep dive. We'll see you next time.